Greetings, everyone. Welcome to the Better Outcomes for Children and Youth Project panel discussion on family clinic partnerships for HIV-positive children. What are the roles of key actors? My name is Susan Kajura. I'm the country director for Botswana, Uganda, and I'm going to moderate this panel. I'm pleased that we have been able to bring some actors from the ground in this important endeavor, which is at the heart of all our work, the Family Clinic Partnership, which brings HIV-positive children into clinics for the support they need. So when we're talking about family clinic partnerships, we're talking about HIV-positive children being identified and getting into treatment and care. What is the process and who kicks it off? I'd like to ask Felicita to tell us, as a parasocial worker, what is it that you do and how do you go about it?
Thank you, Susan. As a parasocial worker, what I do, my role is to identify children living with HIV and profile them together through a health facility team and the CDOs. We assess using the HEART tool to develop the important plans and the care plan according to issues identified, such as adherence monitoring, appointment keeping, viral load monitoring, and suppression. We provide them psychosocial support, educate them on health and HIV-related diseases, and we educate them on nutrition, GBV, and the family planning. We do our parish level community meetings to compile our cases which have been identified in the community. Those we can handle, we handle them and take them in the conferencing for the CDO to close them out.
I want to thank you for bringing out the case management approach. You're the first case manager who enters into the house, and you're able to then identify the social issues and the health issues and address them systematically. And you really appreciate that. It's not easy for vulnerable households. However, we are looking at children who are living with HIV/AIDS, who have now been identified, and the clinic is really the first point of call. So we'll go over to our health center clinic in Mbale and hear from Lillian Nabafu. How are you bringing all these various stakeholders together to be able to help our children, and how have they been impacted?
After we identify these children, we are linking them to the OVC program under the Better Outcomes. And we are also doing the joint identification and follow-up of these children living with HIV who have missed their appointments. Why? We don't want them to miss swallowing their daily drug. We are channeling down to the households and really finding out what the problem is. Why is this particular child not suppressing? The problem could be at home, and when we reach there, we try to identify what it is. Case conferencing at the health facility has also been done, where we sit down and identify these children who are not suppressing. Recruitment and placement of linkage facilitators has also been done at the health facilities. These have been so helpful in the art clinics, whereby they are helping us triage these clients, the children, adolescents, and even further to the adults who are in care. They do the health education. They are following up on these clients who have not come for their ARV refills. So we've really seen the importance of the linkage facilitators.
Thank you, Lillian. I think we can't overestimate what was done during the COVID time. Both Felicita and yourself spoke about it. And it speaks to the commitment of your staff and our community structures to support children and households living with HIV/AIDS. The case management approach we heard from Lillian also happens at the clinic level, where they have case conferences, and Lillian is able to bring in other important actors. We would like to also show that case management enhances collaboration with the school system. In the school system, teachers are trained and sensitized, and they become treatment supporters. They also create a safe space. But there's the custodian of social protection at community and sub-county level, and that is the CDO, the Community Development Officer. And would like to hear from Juliet what challenges the project has helped you meet in terms of your work. Thank you.
Thank you very much. As a Community Development Officer, one of my key roles is to offer social protection to vulnerable persons, and this includes the children. But more specifically, we're talking about the children that are living with HIV/AIDS. Before the inception of this project, I want to say that I had numerous challenges in regards to case management. One of it was not having parasocial workers in place, and because we did not have parasocial workers in place, we had issues with case identification. We had challenges in case assessment and reporting. These were very, very low. We also had issues with the coordination at sub-county level. I also had a challenge with the understanding, the social understanding of HIV. Our understanding is that HIV is a health issue that should be managed by the health workers. But we have left out a very important aspect, which is the social impact of HIV on our livelihoods and on our communities. With the inception of this project, I want to say that parasocial workers have been trained in child protection, in gender-based violence, and in HIV-sensitive care. With this training, case identification, case reporting, referrals, and assessments have been made much easier and have improved very greatly. This has also been facilitated by the fact that bicycles have been provided to these parasocial workers to ease their movement, and provision of the CUG phones that are connected to the different players in child protection. Communication is made easy, reporting is made easy. I don't have to walk a very long distance to look for whom to report. I simply call from my village and it reaches the different actors. I also worked very closely with families, where there are families and caregivers where children with HIV are living, to offer them psychosocial support. This is very important. A child who gets treatment without psychosocial support will not recover. But once we give this psychosocial support, we're able to build the hope of this child. We have also worked very closely with health facilities in terms of referrals. We have defined our referral pathway with health facilities very strongly, in that cases that children of not suppressing, children not having good nutrition are able to get very good care at the health facilities. I also want to thank the project for introducing a very unique, I find it very unique because it has helped us to manage cases, to identify them very easily, and to redirect our intervention given the limited budgets that we have at a local government level. These are the case conferencing which we hold monthly, and in these meetings we call the different players in child protection. We're able to identify the needs of our clients or the children that are living with HIV/AIDS in a multi-sectoral manner. Thank you so much, Susan.
Thank you, Juliet. I hope case conferencing will continue even after the project ends.
Definitely.
That's good.
Yeah.
Because these sub-counties are really large, so to be able to have a meeting that brings all the services together, to be able to discuss the services that are needed, is an important part of the case management process. So we've heard from the village level, we've heard from what happens at the clinic, now at our sub-county, we've heard about the interaction that happens between social work and our health workers. Who coordinates that multi-sectoral approach? Who brings it all together? Is the implementing partner, and with us is Henry Lulu from AIDS Information Center, who works in West Nile and Lango region. Henry, please tell us how you manage this mammoth task.
We developed a memorandum of understandings with these various local governments, both at the district and at the sub-county level. Within this partnership, we worked also closely with other USAID-funded partners. In Western Nile, we worked with the IDI. In the Lango sub-region, we worked with the Rights North Lango. Secondly, we had to bring on board the various cadres that are involved, both at the district level, at the sub-county level, and the community level. We identified the key cadres. We provided the necessary trainings. We provided and told them with the necessary SOPs, with the necessary guidelines, and the necessary job aid to be able to effectively deliver both child protection and HIV services. The third thing that we had to do was to strengthen the weak coordination mechanism, both at the district and at the sub-county level. We were able to revamp the DOVIC and the SOVIC and empowered them with the ability to bring together all the key actors to come and plan, to be able to coordinate and be able to monitor and come together to again evaluate our interventions. The last but the most important thing that we had to do was to use data for planning, for decision making, for programming, and doing so many other things. We have been collecting data semi-annually to assess our interventions. We have been collecting data from our beneficiaries from various service delivery points, and this critically helped us to be able to utilize this data to have targeted intervention and be able to switch off the most critical red flags. And consequently, because of this multi-sectoral approach, we are leaving behind over hundreds of thousands of beneficiaries who are highly empowered, who are able to know where to get the services that they need to be able to move across the HIV cascade and be able to have a sustained viral load suppression.
Thank you. Very well said, Henry. And I'd like to thank all the panelists for all the great work they're doing. They brought out the fact that it's very intentional coordination that is happening at different platforms, at different levels, right from when we began in the home, at the clinic, at the sub-county, and all the players that are involved in this. In Botswana, we call this our socio-ecological model, where you have children at the center, and around them there are circles of support. So the issue is to identify where what are the points of support in this circle, and how do you empower them to work together? And for this, we use the case management model. So I'd really like to thank you for really bringing that out and to show that a clinic-family partnership is possible and children have been suppressed because of it. Thank you very much for being a part of this panel discussion.